Hello, hello. Coming to you on March 16th. I know you don't have these slides, but I'm gonna start with the cortical limbic system. I will post this PowerPoint with these two slides in it, but you have these pictures on e-learning. I did post them there. So I just want to talk a little bit about the brain, because with most of these mental health disorders, they do see some brain changes going on. So I want you to be familiar with those areas of the brain. So the first one I'm going to discuss is right here, your amygdala. And you can see here it tells you processing of emotions. And this is where if you have stress, this amygdala gets fired up, right? This is where that anger and where you feel your body just so that's my amygdala. It also helps with learning as well. Okay, emotion, stress, learning, all part of the amygdala. All right, then behind that, or kind of that HPC is the hippocampus, and you probably heard about that, and that's just learning and memory. And everything is really interconnected. You can see that by the arrows. Then we go to the ACC, which is the anterior cingulate cortex, and right here it tells you reward anticipation, decision making, empathy, emotion, and impulse control. Okay, so think about your person's affect and their attention. Okay, and when we talk about these frontal lobe areas, we do see changes in depression with, of course, affect. And they think that possibly neurotransmitters can be less in in certain of these areas. Okay. And then we go to the DLPFC, dorsolateral prefrontal cortex, and motivation and executive function. Remember that frontal cortex is our higher thought processes. Okay, so those are important parts of our brain, and we call them the cortical limbic system. I really want you to print off this sheet of paper and hold on to it throughout our lectures, because these neurotransmitters play a role in pretty much all of our mental health disorders, all right? You know about acetylcholine. When we talk about acetylcholine, we talk about it fight and flight, rest and digest, right? This is our rest and digest. However, it has also been associated with, depression. So too much acetylcholine is associated with the depression. And it kind of makes sense, because if I get too much, go back to your resting and digesting, what's happening? Everything's kind of slowing down. So there is that potential. All right, and then too little of it is in the hippocampus, has been associated with dementia and Alzheimer's disease. Okay, then going to dopamine. I'm going to tell you dopamine, norepi, and serotonin all play a role when we talk about depression and some of those medications. Okay, so dopamine. When we talk about dopamine, there is some movement. That neurotransmitter is important in movement, but also mood, attention, and learning. Okay. It is, you'll hear dopamine referred to as like the reward hormone. So when we, eat chocolate, do drugs, that sort of thing, you can have a dopamine rush. All right. So it's kind of our reward hormone. Too much of the dopamine has been associated with schizophrenia. And then in parentheses, you can read here, most likely too many dopamine receptors. Okay. And then too little is depression. All right. And then too little as well, dopamine is definitely associated with Parkinson's disease. And so you'll see if they have too much or too little dopamine, muscular rigidity, and tremors. Norepi, too much, has been associated with schizophrenia, too little, depression. All right, epi, we know what epinephrine does. Too much epi can result in restlessness and anxiety. Remember, epi is one of our, what gets released when our sympathetic nervous system gets stimulated, right? And if we have chronic stress in our sympathetic nervous system is continuously being stimulated, I can have restlessness and anxiety. right? And then too little is associated with depression as well. Serotonin, it plays a role in mood, and then also sleep, appetite, body temperature, right? Too much, which can happen when we take antidepressants, which we're going to talk about serotonin syndrome. But if there's too much, you can have heart problems, mental confusion could occur. And like I said, we'll talk about serotonin syndrome when we get to our antidepressants medications. Too little serotonin, again, depression, and some anxiety disorders. You will see when we talk about anxiety, we do treat it with SSRIs. GABA. I want you to think of GABA as the brakes of the brain, okay? It inhibits excitation and anxiety. So this is the brakes of the brain. If I'm going too crazy, GABA, that neurotransmitter, slows things down. Now, think about if I have too much, then I'm going to be overly relaxed and sedated because it's the brakes. So I got too much brakes on my brain, right? And then too little, I don't have enough brakes on my brain. What's going to happen? I'm going to have anxiety, right? And then there's a potential for seizures. And then endorphins involved in pain relief and feelings. I'm not going to get too much into the endorphins. Okay. Next, we are going to jump into mood disorders, depression, and this is your chapter 15, okay? Concepts of depression. Depression is very common. As we know, about 7% of the population will have a major depressive disorder, and you'll see different percentages throughout. I'm going mostly by what your book says, okay? There is a vulnerability to depression. Genetics certainly plays a role. Life stressors can play a role. When we look at populations, African Americans can have a high rate of depression, followed by Hispanics and then whites. And that probably does have something to do with genetics and life stressors. Prevalence and comorbidities. I don't expect you to know these numbers, but it is the fourth leading cause of disability, 16.5%. Again, these numbers vary, but 16.5% will have a major depressive disorder in their lifetime. Comorbidities or other psychiatric disorders that go along, it's very common to see depression and anxiety. They're like brother and sister. They go along together. So depression and anxiety disorders go together. PTSD and depression. Schizophrenia has depression. OCD disorder, personality disorders. So you will see those, we call them comorbidities, but they kind of go together. And then medical disorders, if patients have chronic medical disorders, that can cause depression as well. Depressive disorders, developmental aspects. So just something to know. We do get into children a little bit later in this class, but children have been diagnosed with depression. I think you guys know that HealthSource has a children's ward actually. However, children are not always having the typical depressed symptoms. They might complain of stomach aches or just not feeling well or have kind of vague complaints. Some might act out. They might show aggression or they might be really clingy. So we're going to talk about the signs and symptoms of depression, but children don't always demonstrate those the same way that adults or adolescents do. The thing with adolescents that can be difficult, of course, adolescents have an increased incident of depression, but they can mask it because a lot of times what us older people do is, it's hormones. They're just going through a phase. They could mask it by sulking, being very negative, grouchy, getting into trouble, where older adults or adults might write that off to, they're just young and dumb, right? So we should have that awareness when it comes to our adolescents. And then older adults, their depression actually has been decreasing. However, elderly men are the highest of all groups for suicide, but have decreased. All right, no. Cut that. Okay, so older adults we need to assess as well because they can also mask their signs of depression. All right. SSRIs are too, not usually good for elderly. They can increase their falls, stroke risk, and seizure risk. So that's tricky. However, I've noticed just practicing with you guys in the nursing homes that we do order SSRIs pretty frequently for our older adults. Biological theories related to depression disorders. Of course, there's a genetic component when it comes to depression, as well as childhood stress. Both genetics and childhood stress actually causes changes in the brain structure, all right? I talked a little bit about the amygdala and the hippocampus, and they do see changes in some of those structures for children and adults. You can see the picture I have up here, how lit up the depressed brain is versus the not depressed brain. So there are some biochemical factors as well. Some of the main things we talk about with biochemical factors are the neurotransmitters, and I already mentioned serotonin, norepi, dopamine are the big ones that we talk about when we talk about depression. And then that hippocampus is smaller in depressed people than non-depressed people. More biological theories related to depression, neuroendocrine factors. They think there might be hyperactivity of the, all right, I'm going to say this, hypothalamic pituitary adrenal cortex axis. Now, what the heck is that, right? Well, all that is the way we release our steroid hormones or our stress hormones, okay? This is really this is a big word for activation of our sympathetic nervous system, basically, all right? So when you hear the neuroendocrine factors, think about that, what we're activating. And also the cortisol, which is part of our cut. Okay, the neuroendocrine factors. So hyperactivity of our, now don't freak out, as a big words, but we'll break it down. Hypothalamic pituitary adrenal cortex axis that is implicated in depression disorders. All this is our endocrine system, okay, and it releasing our cortisol, right? And cortisol is our stress hormone, right? And so there's a picture in the bottom right-hand side. Our hypothalamus, which is in our brain, releases a hormone called corticotropin releasing hormone, right? That's really goes down and it talks to my anterior pituitary, and it tells my anterior pituitary to release another hormone, which is my adrenal corticotropin hormone, okay? That floats around in my system down to my adrenal cortex. You guys know where your adrenal glands are. They're the little hats on top of the kidneys, and those will release cortisol, okay? And that is our stress hormone. So they think that there's a hyperactivity there that is associated with depression. And then imaging results, CTs and MRIs show ventricular enlargement as well. Okay. Other theories related to depressive, psychodynamic factors, right? The stress the stress related to environmental and interpersonal life events. Trauma stimulates the stress response. Then it gets depleted and causes some structural changes in the hippocampus. It may also deplete norepi and serotonin. So there's certainly other factors or other... Yeah. The cognitive theory is Aaron Beck. Basically, he says that negative thinkers have a negative view of their self, a negative view of the world, and then that negativity will continue regardless. All right, and then learned helplessness is this is my easy way of remembering. They think nothing they can do will help the situation. Okay, so regardless, and usually that happens from being knocked down so many times that no matter what we do, it's not going to help the situation. Okay, so I think your book gave an example of like older adults. Um, I think your book gave a example of people in poverty feeling hopeless and that no matter what they do, they can't get out of that situation. There was some research done on that learned helplessness too with dogs. That was kind of interesting. They would give these dogs a shock, and then one was given a lever to stop the shock while the other dog wasn't. And so the dog figured out how to use the lever, and the other one didn't. And then when they were given an escape, like so they opened up or they made it so that the dog could escape, the dog that didn't have the lever just laid down and whined, didn't even try to escape, while the other dog did. So they were trying to show that the dog that just laid down had learned helplessness. So just kind of interesting. Okay, moving on to major depressive disorders. DSM-5 is in your book, so remember that's the diagnostic statistical man. I can't speak. Statistical manual, and that criteria is in your book. Two things: the signs and symptoms are usually during a 2-week period, but must include one sign or symptom of depressed mood or anhedonia. All right, and anhedonia just means a loss of pleasure. Anhedonia means a loss of pleasure in life or previously pleasurable things. All right. There are specifiers, and specifiers are just the extensions to a diagnosis that help clarify the disorder. So they can have psychotic, catatonic, melancholic features. It could be postpartum onset, seasonal affective disorder, or atypical features even. All right. So common system. Okay, so common symptoms, emotional and cognitive symptoms. So this is where I would be asking you guys to tell me what some emotional and cognitive symptoms are. So anergia is one, ANERGIA, which is just a lack of energy, right? Anxiety, worthlessness, low self-esteem, guilt, anxiety, helplessness, and hopelessness are big ones. Anger, irritability. Think about cognitive, we think about thinking, right? So their thought process is slow, poor concentration, poor problem solving. They might be really indecisive, right? And then physical, there can be lethargy, fatigue. You might hear this term psychomotor retardation, and that just means slow, difficult movements, with these patients. They can also have the opposite, which is psychomotor agitation. Anorexia or overeating, it just depends on the patient. Insomnia or hyperinsomnia, meaning I sleep a ton or I don't sleep enough. Okay. Constipation, loss of libido, and pain. People with depression complain about pain all over their body. There might be some weight loss, right? And reoccurring thoughts of death and suicide, which can also be a potential. When we talk about, I'm going to talk about a couple different types of depression, but dysthymic disorder, you might see it DD or PDD, persistent depressive disorder. It's commonly known as dysthymic disorder, or you might hear it called chronic depression. Okay, so this is different than the acute depression that we might come into contact with. This is not quite as severe, but it's been present for at least 2 years. So duration is a long time. The major difference between this and just depression is the length of time, and it's less severe. Okay, that's the biggest thing to say that it's a dysthymic disorder. There are some signs and symptoms on page 202. You can look over that, but typically they can function at work, but they might be just really pessimistic thinkers or very irritable people. All right, but they are functional usually. Okay, so assessment guidelines. There are a lot of different standardized tools for depression. I think I gave you one last semester with the elderly population. We have a depression screening tool, but oops, I'm sorry, I jumped ahead. Ooh, I'm going back. Okay. So just know that there's a lot of different tools out there. We need to evaluate the patient for suicidal ideation, and we're going to be talking about suicide and suicidal ideation towards the end of this lecture, so I'm going to leave that evaluation for that lecture. Determine the presence of other medical conditions. There certainly are other medical conditions that can look like depression. The other thing we might want to know is there a support system in place right with this patient, and was there any triggering event that started the depression? There does not have to be a triggering event. I just want to put that out there. Okay, so we should focus our interventions on the specific symptoms, right? And then what do we need to teach our patient and family about depression, right? So we really are looking at the stage of the depression, where they're at. Excuse me. Okay, so we really want to treat the depression at the stage that they are at. So keep in mind, some patients that are depressed can be severely withdrawn and not really communicate. But it is important to you to be there and be present for those patients. You will see on page 207, there's communication techniques for severely depressed. Go ahead and just read that box. The other thing is, for most of our mental health disorders, you're going to hear me repeat the same treatments. Okay, so usually it's some kind of psychotherapy and medications as well. Other things to keep in mind when you're speaking with somebody that's depressed, remember there's a slower slower thought process, so you're going to give them more time to reply to communication. If your patient is not communicating with you openly, you can always make observations related to surroundings or the person. And then just listen carefully for covert messages. What you're trying to do is just kind of draw that patient out. There is a good vignette in the book. It's on the same page too, page 207, about a nursing student not really feeling useful because her patient wasn't speaking much. Sometimes a patient just needs your presence. All right, question. Which question would be priority when assessing for symptoms of major depression? Tell me about any special powers you believe you have. You look really sad. Have you ever thought of harming yourself? Your family says you never stop. How much sleep do you get? Or D, do you ever find that you don't remember where you've been or what you've done? And so the correct answer is B. But I need to update this PowerPoint because since this has been made, we don't really want to ask when somebody, and again, we haven't talked about suicide yet, but when somebody's suicidal, we don't want to say harming yourself because we want to ask directly, are you thinking of suicide? Not harming, because sometimes the association of suicide and harming do not go together. Okay. So treatment for depression, antidepressant medications. There are advantages and drawbacks to these medications. The advantages are they can work. They actually can work, right? I think I have, let me just go to the next page. I do. Okay. So let me talk a little bit about advantages and drawbacks. Advantages, they have been found to be effective for some people in the population. So that has been really a godsend and a lifesaver for a lot of people. Some of the drawbacks when we talk about antidepressants include the length of time that it takes for those medications to start taking effect. I like to say, just for testing purposes, 4 to 6 weeks. Okay. Now there are depression medications out there that are gonna work a lot quicker than 4 to 6 weeks. That might only take 2 weeks, but generally speaking, I'm just gonna say 4 to 6 weeks. Okay. The other drawback is our black box warning. I think if you gave an antidepressant at all in the past semesters, you know that they are at an increased risk of suicide in children and adolescents. So that is something that can be concerning when we talk about the black box warning. The other thing with antidepressants is, and I guess I would put this under the advantage, and I believe I posted this is in your book on page 211, the neurobiology of depression and the effects of antidepressants. But what's interesting down at the bottom is, depending on the patient's problem, the psychiatrist can order the appropriate antidepressant. So if the patient is having a fatigue with their depression, they're going to order fluoxetine. It's an SSRI because it stimulates the CNS. And if I'm taking one that stimulates my CNS, I want to make sure that I take my fluoxetine in the morning versus at night. Now, flip that around. If my issue is insomnia, my psychiatrist can order a medication that makes me sedated, then I would take that medication at night, and that would be something that would help. So there is different things that we can do. I have found with antidepressants, with all mental health medications, it is not black and white like our beta blockers, our ARBs, our ACEs. I can't say this will equal this. I have found that a lot of psychiatrists are trying different types of medications to see how it works for that patient, and if it doesn't work, then they try something different. And it's really just trying to find the right fit for each patient. There's no one answer for our mental health disorders. All right. Some of the safety considerations, well, the one, again, that black box warning, of course, is going to be a safety consideration. We worry about our elderly population on antidepressants because of the side effect profile that goes along with it. We worry also about the length of time. Sometimes patients commit suicide. Well, I already said suicide's a risk, but that can be a big cause or a big concern. And then depending on the type of antidepressant that your patient is taking, there can be safety considerations. So I'm just going to flip to the next screen. I know you don't have this screen. However, I did post this graph on e-learning. This was going to be an in-class activity where you guys looked up the medication and talked about the nursing interventions related to the medication. So clearly we can't do that. If I had to pick out of here the most common classification, it is, I would say, the SSRIs, followed by the SNRIs that we see pretty frequently in being ordered initially. All right. Now, I really just group the side effects together. Depending on the type of medication that your patient's getting, there might be different side effects, but there's a lot of information for each of these medications. So let's talk about the SSRIs first, okay? All those do is increase the amount of serotonin in the synapse by blocking the reuptake. And I will post a video, let me write it down. I will post the video regarding this so that you can kind of just see how that works. But the SSRI just leaves the serotonin in that synapse between the cells so that there is more of that. Because like I said earlier, excuse me, serotonin plays a role in mood, right? And we're thinking that with depression, there's not enough serotonin there, okay? So I have on here, it says less side effects than TCAs, and that's the tricyclics that's above it, and that's probably why these are ordered more frequently than the TCAs. The most common side effects: nausea, vomiting, diarrhea, dry mouth, sexual dysfunction, and black box warning. Now I do have in there serotonin syndrome. I have a slide on that coming up. We'll talk specifically to serotonin syndrome, but that means you have too much. It's pretty rare syndrome, and usually it just happens if you're taking more than one antidepressant and you have too much serotonin, but does not happen very frequently. And then we have to educate. So for our nursing interventions, we've got to educate on sexual side effects that can cause people to abruptly stop. I will say, generally speaking, on all our antidepressants, we do not want to abruptly stop them. Okay, and let's talk about all of these, and then we'll talk about, generally speaking, education that covers all of our antidepressants. All right, it may cause insomnia or drowsiness. It just depends on which one you're taking, which SSRI. I have down here no MAOIs, and we'll talk about MAOIs. MAOIs can really increase the serotonin level, so that if you have MAOIs and an SSRI, you have the potential for serotonin syndrome. That potential will go up a lot. All right, so if your doctor prescribed MAOIs, they have to be discontinued for at least 14 days before SSRIs. I'm not really sure. I can't imagine why somebody would, or why a psychiatrist would prescribe MAOIs prior to SSRIs. I feel like you would get rid of that. So let's say your SSRI is not working and your doctor wants to switch you over to a MAOI. They have to wait at least 14 days because that will put you at a higher risk for serotonin syndrome. All right, then moving up, I'm going to go to tricyclic antidepressants. Common names are amitriptyline, Elavil is the name for that one, and protriptyline. I'm not sure if I'm saying that right. So what these do are they inhibit the reuptake of the norepi and serotonin. So it increases both norepi and serotonin. But these have higher side effects. Cyclics can have anticholinergic effects. So think about what some of those anticholinergic effects are, right? Orthostatic hypotension is a side effect and may have sedative side effects. Cardiovascular effects such as tachy-MI heart block, and those are the big reasons why we don't see these prescribed as a first-line treatment. Overdose of cyclics can cause life-threatening arrhythmias. All right, so what are we educating our patients on? Again, the length of time it may start helping is 10 to 14 days, but it could take up to 8 weeks. Preferably take at night, but again, before I say that, make sure that we're looking at what medication it is. Anticholinergic effects, we know dry mouth, tachy, constipation, retention, drink lots of water, fiber, exercise, and then dangle and change positions slowly. All right, and then SNRIs, again, those are specifically looking at leaving more of the serotonin and norepi. They are similar to SSRIs. They can cause hypertension, and so your education, I have just a little quotes, air quotes, just make it the same as SSRIs. Then our MAOIs, those prevent, and so again, it's monoamine oxidase inhibitor. So we've got the word oxidase. That's the monoamine oxidase is an enzyme that actually breaks down my norepi, serotonin, and my dopamine. So we want to block that enzyme from breaking down those neurotransmitters, right? So there's lots of side effects to these though, and so these are not prescribed that liberally. They can have stimulatory effects related to the dopamine increase, so patients complain of palpitation. Think about stimulating our sympathetic nervous system. Palpitation, tremor, insomnia, anxiety, and dizziness. If a patient has a history of heart, liver, or renal issues, they should not be prescribed this. There is black box warning because if a patient, and you'll see this in the nursing interventions, if a patient eats tyramine foods, it can really increase the heart rate, make it deadly, so, or heartbeat, or increase the blood pressure. So they have to stay away from tyramine foods. And tyramine is found in aged cheese, wines, nuts, chocolate, fermented meats. There are a lot of drug and food interactions with this medication. So this one in particular, patients really should have some kind of medical alert card or bracelet. And then we got to watch that blood pressure. So these are your, there's other, there's atypical antidepressants. I'm not going to get into those too much, but these are the big ones that we tend to talk about when we give antidepressants. Now, let's talk just about some overall general education for all our antidepressants, okay? So if my patient is prescribed an antidepressant, I want to make sure that we know there's a suicide risk, right? So that's something that needs to be known. They should not stop abruptly. They should not be drinking any alcohol while they're taking their antidepressants. If they are on an MAOI, they really need to have the safety alert band. Have an understanding that taking it is not gonna, they're not gonna feel the effects instantly once they start taking that medication. If they're gonna be adding in any other medications, that they should really get that cleared with their healthcare provider before they do, especially medications that affect the CNS or the central nervous system. Okay. All right, I'm going to move on to the next slide. So, symptoms of serotonin syndrome. This, again, happens when there's too much serotonin in our system, right? This is very rare symptoms, or this is a very rare condition. So some of those symptoms include hyperactivity, muscle spasms, tachycardia, hyperpyrexia, which means a high fever, and high blood pressure. Treatment, all we can do is treat the symptoms, right? So we have to stop the medication and then just provide supportive treatment. They might use some medications such as Valium or diazepam for muscle rigidity. They might use anticonvulsants or even maybe paralyzing agents just to sedate the patient until we can get them through this. Now, I don't want you to get this one confused with neuroleptic malignant syndrome. That one is one we talk about when we talk about antipsychotics. But this is the main, this is serotonin syndrome is the issue. All right, so let's say we try all of the medications and none of them are effective. As a last treatment, there is electroconvulsive therapy. Please watch this video. I do have it posted in e-learning as well. Some of the potential adverse reactions to, let me first say this is not a first-line treatment. Usually it's used when nothing else is effective. This is for depression, not treatable by medications alone, right? So some of the potential side effects after ECT is done is a headache and memory loss. Those are probably the two biggest ones. There's also brain stimulators that have been used as well, and I don't know too much about the brain stimulators, but those can be placed in to increase neurotransmitters. Some of the other treatments for depression, light therapy. This is what's used for seasonal affective disorder. That's for people in our hemisphere at this time, like Michigan. When I have action underneath there, all that does is that that light stimulates or simulates the sunlight, and it helps with our circadian rhythm and helps us to release some serotonin and melatonin. Okay. The hope is that with that release, that we have natural sleep cycles and you start feeling a little bit better. Okay, so that was my depression lecture. I'm going to stop this recording here and I will start another one for bipolar spectrum disorders.